Good afternoon, good evening, wherever you are. It's lovely to see you. Happy Friday. Welcome to the open online briefing. We're super excited to have you here today. Lots of movement in the COVID world, not least because there continues to be hundreds of thousands of cases every day and thousands of deaths. So looking forward to David's update. Just a reminder to everybody that we do record these. You should have gotten that notification when you signed on. And we do post these on the 4SD website. So please feel free to say anything you'd like. And if you want us to edit something out, just let us know. I'll make sure that Mihika and I have our addresses in the chat. But I don't want to take up anybody else's time. So greetings from Los Angeles, Autumn Learner. That's great. That's far away, 9 hours behind. Welcome, welcome. And so just a shout out to my home city. But on that note, back to David. David, we can't wait.
Thanks very much. If Paul Garwood comes on, could one of you send me a WhatsApp quickly?
David, just to let you know, Gregory is here.
Gregory, you're here. So everybody, this is an important new departure. We have people from the communications team in the WHO who are joining us, and Gregory Harold, who actually I've known for some time. When I was in WHO, Greg was there. Just to explain how we work, Gregory, usually I give a fairly short update based on what I'm seeing around the place, and I try to offer my view of the pattern of what's happening and my view also of how that pattern is evolving. That sometimes takes us a little bit out of sync with what others are saying. This is a pretty independent place. And then after that, we invite different people who are here to comment. And we know that we have usually people here who have experience of long COVID. We have people here who have experience of COVID in different parts of the world, including in Africa, in Nairobi, I can see, but also the experience from Asia. And then we have people in various roles in the UK. And we've got Frank Atherton here, who will give us a pretty important perspective from Wales. And I'm planning to go to him very early on in case he needs to leave quickly. So basically, please come, and if particularly when we get to things that you want to talk about, please make sure either by raising your hand, Gregory, using the reactions function, or by catching my eye that you want to come in. And it is not just a David talk shop, it is a group thing. But remember how we tend to approach COVID. Right from the beginning, we've said this is a communicable disease that tends to really affect poor people much more than others. It is a disease that really requires the ingenuity of all of humanity to respond to it. There's so many things we don't know about the virus and what it does when it tangles with people. This is a disease of which the uncertainties are so great that we actually feel also we can't spend a lot of time critiquing different political decision makers and public health positions. Well, instead, what we want to do is to observe and learn. And always in these sessions, our colleague John Atkinson, who we like to portray as our systems leadership guru, is here and makes comments on what he's seeing and hearing. Sometimes they are extremely important to all of us, and we take them away and we reflect on them, because all the time we're learning how to apply systems thinking and systems leadership to this issue. We believe that that is important for good public health action. John, it's so good to see you here again. So what we've been trying to do really since we started over 2 years ago is to constantly establish together a story, a narrative about what's going on, and then to weave it together with the perspectives of all of us who are here, so that our story evolves in a very rounded and holistic way, and involves with us working together. And so the simple part of the story right now is what we've always said we were thinking we were going to see, which is this virus is here, is continuing to surge in different places, and it is surging sometimes in a fairly unpleasant way because the virus is capable of mutating so that it can overcome the immune protection that we might have. And so we end up with people being reinfected, possibly quite often at 6-monthly intervals, perhaps, but we also end up with immune escape. But the joy is that over time, the virus has evolved so that its target appears to be less the alveolar mucosa deep in our lungs. It's now seeming to attack higher up in the respiratory tract. And that does mean that at least when they get the acute illness, most people are not at anything like the danger they were 2 years ago of going on to severe illness, hypoxia, and then perhaps even death. No, the death rates are fortunately now really quite low. People who do seem to be at risk of death are still the people who've got other predisposing factors like certain illnesses, including diabetes, including cardiovascular disease. Also, it tends to be older people, and it tends to be people who are immunosuppressed, and it tends to be people who are not vaccinated. There's no doubt, absolutely no doubt, the vaccination saves lives big time. And so it's surging. We don't know how much it's surging because the whole testing business has been cut back on. So all the data about new cases, although they're still being collected by the WHO and others, we don't really believe them very much. What we do know is that this virus is constantly evolving. Right now, it's variants of Omicron, BA4 and BA5 that are becoming more and more dominant. And they do seem to lead to a pretty nasty illness. And certainly you're not super well protected against those variants if you've had, say, Delta or Beta or even the original Wuhan strain back in 2020. And so absolutely key at the moment is widespread surveillance. And that means population-based sampling with good study of the actual virus characteristics in order to identify where the virus is and who's most at risk. And then using that information to remember those 3 Ps that we always keep talking about. You want to try to prevent transmission, especially when transmission rates are high, by, at least at the moment, focusing on masks, which seem to reduce infection rates by 30 to 50%, depending on the circumstances in which they're used. Physical distancing, which matters a huge amount. It's harder with these highly transmissible strains. And then when necessary, actually really physically shielding people and keeping them away from others, perhaps even through movement restrictions. Then the second P that we talk about is protecting people. And that's where we've said all the way that the vaccine is the best protector. And so you're doing an immunological protection. And if we had any magic wand that we could apply, it would be say, could all people over the age of 60, 65, that sort of area, please be making certain that they've had not only 2 basic vaccines, but 2 follow-up vaccines, if at all possible. Really, everybody should be doing that. And the big question I have for myself, having just had COVID 2 weeks ago, is when should I have my 4th shot of one of these mRNA vaccines? I'm tempted to go and look for some pretty soon. And then the third thing is that we need to prepare for surges, because quite honestly, when these surges come, it's very muddling if people really just do not know what's expected of them. Right now, that's a bit difficult. We're in a phase where there's not much room politically for reintroduction of mask wearing in particular settings. There's not much joy about any kind of government mandated action in relation to this virus. I think that's a temporary thing, but it'd be interesting to hear from all of you as to what is the political space for public health action right now in different settings. All the work that we're doing is about systems. I think that we've really reached the position that lockdowns are not to be used as a primary means of stopping transmission, if at all possible. I know there's still some countries that are using lockdown quite extensively. We're saying no, if you possibly can avoid it. Remember just how much damage lockdowns do to the livelihoods of poorer people, particularly people in the informal economy. And I've just been reviewing the data on this because of my role in the UN's Global Crisis Response Group. The world is in the most terrible cost of living crisis because of rising food prices, rising energy prices. And a lot of this is to do with the impact of COVID lockdowns that were put in place in 2020. Yes, there's additional factors like climate change and conflicts, and particularly the Black Sea conflict right now. But we got to remember that if you dislocate societies the extent that they have been dislocated globally by the amount of locking down that did occur in 2020 and 2021, the knock-on effects can be quite devastating, and they are. And the cost of living crisis is to some extent being really triggered by COVID-19 responses. And so we're saying, if you want systems to work, try to be very careful with these draconian measures like lockdowns, and look for more sophisticated ways of helping societies get on top of this virus, mostly by enabling people to have access to as much information as possible. I know that people will say sometimes if you share all that you know, you might be scaremongering, especially when it comes to talking about the dangers of prolonged COVID, which we will do this evening. But I'm going to say that on balance, I'd much rather be sharing what I know within a spirit of trust and dialogue than holding back because of being accused of scaremongering. Be very interested to know what you all believe is the best way to get systems working together in a virtuous way. Of course, all this work requires solidarity, solidarity everywhere, between different sections of society, between different political groups, between different religious groups, obviously between different nations, and then between blocks of nations and right across the world. And without solidarity, dealing with a really complex and tricky virus like this one, a virus that we really have not fully understood, let alone learned how to get ahead of, so without solidarity, it's just so hard. And to a degree, the world has tied its hands behind its back and tied its feet together when it comes to dealing with this. Solidarity has not been on our side. We're going through a period in world development where solidarity is a bit of a luxury. And so all of us in this group have seen examples of community level solidarity on an extraordinary, sophisticated and advanced degree. And I think we are very inspired by that. And we hope that those who have taken to somewhat undermining solidarity, sometimes even deliberately stoking discord for political reasons, we hope that they will just calm down a bit, because this is not the best way to get on top of a nasty virus, nor is it the best way to get on top of the destruction of nature, nor is it a good way to get on top of vast mass migration, which is on the increase because of the cost of living challenges, nor is it a good way to tackle climate change. Solidarity is what we're all working for. And lastly, just to finish, I'd like to just simply remind you of what we're seeing from around the world, just a few snippets that we've picked up as we look at different regions. In Europe, there is no doubt that there is a new surge happening. It's difficult because you can't pick it up on testing data, but you just need to hear from people who are in Portugal about how hospitals are really quite full, not necessarily intensive care units. And then there's been an uptick in hospital admissions in the United Kingdom. It's not expected at this time of year. And this seems to be probably subvariant related cases, BA4 and BA5. We'll hear in a minute whether this is being reported from those of you who are involved in public health and clinical medicine. And then the upticks that we've been reporting from Southeast Asia continue. There are upticks in cases in Germany. There are upticks in different parts of the United States. And so I think it's fair to say that there is most definitely across the world a surge occurring. It's come about 5 months after the last surge, a bit later than we were expecting, but it's there. And really, this needs to be carefully watched and understood. In my own work, where I've been asked, for example, by broadcast media, what do I recommend? Do I think that mandates need to be reintroduced? I'm stressing that I'm not greatly in favor of mandates. I am in favor of dialogue. I'm in favor of agreement between people as to what their masking policies should be, whether it's in places where it's in companies or in residential care for older people and the like. But I am saying that in my view, still, we should try to do everything we can to avoid doing things by mandates or by compulsion. We should be trying to do it by collective action and partnering. And remember that underneath all these difficulties that we've had as a result of cessation of economic and social activity during 2020 and 2021, we have seen health services really being very badly damaged. Care for people with non-communicable diseases and mental illness has declined. Quite honestly, we are trying very, very hard indeed to encourage recovery. And that means finding ways to live with this virus without needing to stop stuff when it starts to surge up again. We still don't know fully why there is quite a lot of acute hepatitis occurring in children and young people. Hepatitis that was reported first from within the United Kingdom, really, about 6 weeks ago, and now 700 children in 34 countries reported to WHO. The disease that's claimed 10 lives and required a number of liver transplants doesn't seem to be due to any of the viruses that commonly cause hepatitis, doesn't seem to be a direct result of COVID, but it may be as a result of adenovirus exposure. So we'll hear more about that. And secondly, the more than 1,600 confirmed cases and 1,500 suspected cases of monkeypox reported to WHO from 39 countries. Now, these are the 7 countries where monkeypox was often reported and 32 newly affected countries. There have not been deaths in the newly affected countries, but a lot of head scratching. What's going on? And in the meantime, the emergency committee of WHO is meeting and will rename monkeypox for reasons that I think many of you are aware of. So those are some early remarks. I'm going to move straight into conversation. Frank Atherton, please. Thank you for joining us. It's lovely to see you. And by the way, Frank, I loved reading your report. It's absolute tour de force. So many things I learned from it. Please take it away.
Thank you very much, David. I'll put the report in the sidebar later and folks can have a look at it. David, you know, this is just to build on really what you're saying. You know, we've been very fortunate in the UK over the last, I would say, 2 months really, where we've been coming out of the Omicron wave, and things have been moving in the right direction. The various restrictions that the different countries have been removed at different rates. Wales was the last country to we've been a bit more cautious in Wales than other UK countries, but we've removed all of the mandates, all of those restrictions now, and we're relying on public behaviour really. But we are moving into that next wave that you describe. Just today we had the latest ONS figures, and there's a lag on those. This is a systematic survey, sampling survey, and so it's about a 2-week lag in it. But the rates in Wales at the moment are 1 in 45, and a week ago they were 1 in 75. So it's moving, fairly quickly, and that does reflect what you're saying, which is that BA.5 subvariant does appear to have a transmissibility advantage. It's overtaken BA.2 in all the nations apart from Scotland. So that's what's driving this. And we're also, as you rightly say, seeing an increase in hospitalizations here in Wales. I think as of yesterday, there were 15 more patients than the week before, and that follows a sustained period of reduction. But ITU capacity is just rock steady. We've got a residual number, about 8 people actually in ITU beds, but that's been pretty steady, as you'd expect. So what we believe is happening is that there is some waning immunity again. So some of our over 60s, David, they've had more than 3 months since their last booster, and so they are a little bit well, that's that 3-month window. I'm glad to hear that you're recovering well from your encounter, but that might help you with your calculations as well. So where do we go? And then we do look, as you do, at David, at other countries, and we've seen the same thing in Portugal. We've seen the same thing in Germany and France, and we've seen actually in the Nordic countries are experiencing something similar as well. My kind of expectation, I'm always asked by politicians to look into the crystal ball, and I'm anticipating this will be a smaller wave, probably 4 or 5 weeks in duration, but it does just emphasize the cyclical nature of this, and I've been saying for some time to people that it's not gone away, and it will be coming back in different waves. And what we have to hope, of course, is that there isn't something really nasty coming out of the evolution, and something which takes us back to the bad days of Delta. So what are we doing now? Well, as I say, I've been saying it's not over. There are things we need to do in Wales, not least surveillance. We're building our surveillance. You're right, we've moved away from mass testing. We still have some degree of testing for symptomatic people here in Wales, but we are moving towards surveillance, and that will involve both the ONS study, which gives us a good window onto what's happening. We have a Siren study, that's a study where healthcare workers and social care workers are swabbed periodically, and that gives us good information. We look at everybody who goes through our hospital systems with acute respiratory infections, so the SARI, severe acute respiratory infection surveillance. We're boosting that up, making sure all of our hospitals are doing that in a proper way. And we're trying to reinvigorate something which has fallen away a bit. Every year in the UK, as you know, David, we used to have community surveillance through Sentinel GP sites, and of course we're trying to expand that group, get GPs on board fully, get some pharmacists involved in all of that, and so that will give us another window. So getting as much intelligence as we can on all of this. That's the first thing we're doing. The second thing, thinking very much about boosters in the autumn. We're thinking about, David, you didn't mention flu. I know I was interested you didn't mention flu, but of course we've got flu resurging in the southern hemisphere at the moment, and I'm very fearful of flu and the possibilities of co-infection in the winter months. And so we're working towards, hopefully, a combined program of COVID boosters and flu boosters, trying to align the groups that have those so we don't confuse the public and everybody. But that's going to be really important in this season. So that's the second thing, getting vaccinations up and running. And the third thing, you touched on it, David, it's about working with our communities, because I've been saying, we don't have restrictions anymore, but there's sensible things we can do. And the most sensible things are when the thing is surging, when inevitably we go through these waves, we need to, I think, try and work with the public so that they understand that there is a time, perhaps a seasonality to this, and in the winter months it's reasonable to don masks. If you're going into a hospital or a care home, it's reasonable to put a bit more distance between yourselves and your fellow human beings, and it's very reasonable to isolate yourself if you have symptoms. That's easier said than done. It's easy for you and me, possibly David, but it's not easy for people who are in lesser paid jobs. So there's something about social solidarity and building up the social protection networks around those. So that's kind of where we are, I think, David. And I will, if you allow me, just put the report up in the sidebar. It's called Restoring Our Health, and I've reflected on the stagnation of life expectancy and disease mortality reduction here in Wales. Also on the second phase of the pandemic, and a bit on climate change as well. So I'll put that up, and a little bit of bedtime reading.
Do have a read. It's beautifully written, everybody. and you can look at it on your computer. It's rather long if you print it out, and it'll use up a lot of your toner. It's beautiful. Yes, thank you, Frank. Frank, what's the morale like among your GPs, among your district public health officers, among all the people that you're connecting to in the political sphere as well? Are people just so fed up that they just tell you to buzz off, or are they will engage with you?
It's a great question, David, because it's not universal, but there is a sense of weariness in the workforce. They've been through an awful lot, and we've come a long way from those days when in the UK the NHS used to get a clap. Nowadays people are more demanding of services again. So we have a system under stress, under pressure. We, in the same way, we have other people, we have other clinicians who are frustrated they haven't been able to do what they've wanted to do for the last 2 years. Some of our surgeons are just itching to get back to kind of doing stuff. So it's a bit patchy. I think the unions tend to overplay the exhaustion of the workforce. People come to work to help people to do a good job. People do need a rest though, and they need respite, and people are enjoying kind of getting back to a little bit of normality, as we all are, I guess. So it's a mixed picture, and there is a real job to re-motivate and re-enthuse the workforce. Conferences are kind of starting up again, a bit to my surprise. Some of them are in person, and I'm getting invited to a lot of them, and I don't sense that obviously there's individuals who have been quite badly damaged by all this, but by and large people are resilient, but we do need to rebuild the enthusiasm of the workforce.
Thanks very much indeed. That's Frank Atherton, and we are super pleased that he comes and joins us. We've also got Ondine Sherwood and others from the long COVID community who I always love it when you can just share a bit what's going on in your world. I don't know, Ondine, whether you'd be willing to come on in, and I'm just thinking whether who else is here from the long COVID community? Well, that's right. Well,
Sammy McFarland is here.
Yeah, okay. Well, Ondine first and then pass on to Sally, or would you like to do it the other way around?
I don't mind.
You start, Ondine.
Okay. Thank you very much for having me. Yes, we're in a slightly different world, I think, a contrasting world to that of the last speaker, because people with long COVID are very cautious about this idea of opening up. Quite shocked to hear the words post-pandemic on the radio, because we don't feel that the pandemic is over. It's quite scary to be mixing in crowded indoor places because, and I'm speaking from personal experience, a reinfection is very unwelcome. Although we accept that once you're vaccinated, with Omicron, I think it's more to do with vaccination than the strain. The disease is milder. We're not worrying so much about ending up in hospital, but we do know that mild disease produces long COVID, and we don't have enough data as to what it does to people with long COVID or people who've recovered. But certainly the risk of getting all those symptoms back if you're on the way to recovery, or having your symptoms exacerbated if you're still really suffering, is actually a very unwelcome prospect. And so I find myself in a minority in public places because I'm wearing a mask, and I feel like a bit of a freak because nobody's wearing masks anymore. I've been on planes and trains. I've been to weddings and had to stand by the door, and it's as if we're in a different world. And I feel that we feel that the alternate reality is out there, that in fact we are more realistic about the dangers faced, because most of the public don't really appreciate quite how unpleasant long COVID is, quite how disabling it can be, and also quite how common it is. And so we're seeing people getting reinfected. Some get better spontaneously, which is fantastic. Some have a bad experience and then get back to their baseline. Others are really knocked back by a reinfection. And the other thing that I brought up this morning on Independent Sage is that we're also seeing people who didn't get long COVID the first time round. So they think, okay, I'm not going to get long COVID. I didn't get it. and then they get reinfected and then they don't recover. So that sort of raises the spectre of an ever-growing pool of people who could get long COVID. It might not just be the 10% the ONS have identified. Maybe as everyone gets infected and reinfected over months and years, we'll literally get more and more people not getting better. And with recent research that's just been published showing the impact on hearts, brains, particularly on cognitive function, and on long-term health, long-term cardiac and vascular health, even for those who don't realize that they haven't quite recovered. It seems to be a bit of a serious problem. I think we're looking ahead at a rather less healthy population. So I suppose that's how it seems to us in the long COVID world. I'll hand over to Sammy.
Yeah. Well, thank you very much indeed. And we're so grateful to both Ondine and Sammy for being with us. Sammy McFarlane, please, from Long COVID Kids.
Thank you, David. I'm glad to hear that you're feeling better. Yeah, so we are seeing reinfection in children 2, 3, 4, 5 times, some children, and parents are reporting reinfection within 12 weeks of original infection. These are, with tests to evidence. Obviously, that's getting more challenging now because testing has changed in the UK. I'm really interested in the ongoing discussion around the hepatitis, because we were reporting right back in 2020 that families were showing us photographs and reporting their experiences of yellow eyes, yellow skin, and nobody was interested. And elevated liver enzymes and these kinds of things are regularly discussed in the group, and the families are told nothing needs to be done, and that their children will get better, but yet they're not getting better. And I'm repeatedly told by clinicians that children with long COVID get better. And having observed now 10,000 families coming through our support services, we see very few families reporting that their children are getting better. And I cannot express my concern about this enough, because we are, 27, 28 months now, some of these children have not been able to go to school, have not been able to socialize, are not able to live a normal life. We do see some reports of families saying really positive post, my child's done well, they're back in school, they're not reporting any issues. And then a couple of weeks on, we'll get another post from the same parent saying, I counted my hen's eggs, I forget, that's not quite right analogy, but you know what I mean. I put everything, that's my own brain fog, I put everything into that believing that they were better, and actually when they tried to resume normal life, even using the pacing strategies that we promote heavily in our services, they're still not able to maintain normal function without relapsing. And this recent sort of wave has really shown us a lot more neurological symptoms the children have, a lot more issues with abdominal pain specifically, brain fog, cognitive issues, memory, sensory overload, so noise, sound, overwhelm in situations outside of the home environment where it's a lot busier, and these can cause relapses which last weeks, and often are really harrowing for the families, because there's no specific thing they can point it on other than this sensory overload. And then that becomes a cycle of how do you move forward with that if your child can't deal with any sensory experience at all. So really unfortunate times actually from our point of view, and still nothing in schools to prevent children from getting infected. Thank you.
Super important. Thank you very much indeed. Just to say, it is quite tricky if you have recently had COVID and you're worried whether you're actually going to have long symptoms, to just be conscious of how promiscuous movement is at the moment, in terms of people really just doing whatever they want to do without any kind of thought as to restricting contact. It's totally difficult, as Ondine said, to yourself be masked and be distanced and so on, at the same time not to be treated as a freak. Thank you very much indeed for bringing that up. And just to Sammy, thank you for mentioning that there are slightly larger numbers of kids with neurological sequelae coming to your attention in the context of the current subvariants. Very interesting indeed. If anybody else wants to make any comments on long COVID from a personal point of view or what they're seeing, please put a note in the chat or raise your hand. Just to say, the people that I would like to call on now include Iman Ahmed, if you've got anything briefly you'd like to add, NK Seti from New Delhi, if you'd like to bring anything in. And even though they've got not very good internet, I would still like to give Joe Nichols and Megan Matefa a chance to say hello. And if it doesn't work, we'll quite understand. I'd like to go, if it works, to Autumn Lerner, who's part of the Pandemic Action Network, to hear what's happening in your space. I'd like to go to Gregory Harold to hear what's on your mind in the whole WHO communications arena, and how does all this feel from your perspective. I'm definitely wanting to go to John Atkinson. John, I mean, either you come in when you want to and just unmute and I'll see you, or you put your hand up when you're ready. And anybody else who feels moved by the shape of the conversation, please do so. I mean, these are issues for which there are no simple solutions. And if our colleague Frank Atherton would like to come back in at any time and comment on what we're talking about, that would be very good. Just to say, Richard Longhurst, I saw your video was on just now. It's always nice when you have a moment to speak. Ditto Jean-Luc Poncelet. So don't hesitate to put your hand up if and when you're ready to come in. That would be really, really nice. Let's just go to Iman Ahmed. Would you like to speak?
Hi, David and everyone. Thank you for the opportunity. My observations, first from Ontario, I wouldn't speak about the entire country. I'll focus on my province. So what we have done so far is we have moved away from daily reporting to weekly reporting. We are not reporting the cases from schools and publicizing that data. And mask mandates are being lifted in nearly all settings, public transport and hospitals as well, which is a bit strange for me to lift mandates in hospitals. In other public settings, they have been lifted much earlier. COVID testing is not readily available, and it's being charged at a cost, and you can't really know where to find it. So things are being a little bit not community friendly in terms of publicizing information and making things accessible to the public. In terms of our thinking overall of the emergency management or our encounters with such major emergencies, my concern is that people are now just like taking a deep breath, and there is a collective thinking that, okay, pandemic is behind our backs now. But soon enough, we can find ourselves in a new major public health emergency or climate emergency and so on. So my fear is that we still haven't really done that learning in terms of incorporating emergency preparedness and system readiness into our day-to-day function. Thank you, David, and everyone.
Thank you, everybody. That's Iman Ahmed, resident of Canada, originally from Sudan, super well connected to both the diaspora and people at home. It's always lovely that you're with us, Iman. Thank you for sparing the time. To NK Seti, public health doctor, former member of the Planning Commission in the Government of India, connecting to us, I believe, from New Delhi. How's it going, NK?
Thank you, Dr. David. I'm no longer with the Government of India. I was an advisor, but not now. I'm just a freelancer now. Now, yes, right now I'm in Delhi itself. And in India, we are again seeing a surge. And what I observe that people have become, whether mass mandates come, go, but people have become complicit. And in general, even the medicos feel it's mild, so what if it happens? So my feeling is that we need to think how best to bring about a behavioral change communication, and while doing so, communicate about long COVID, which has been very well explained, but people simply don't register that. That's what my observation is. One. Second, yes, you rightly mentioned about surveillance, and I believe it has to be a multi-pronged surveillance, because as such, people are not going in for tests, they are not bothered about it. So basically, community-based surveillance, sentinel surveillance, facility-based, as well as lab-based, and maybe zero surveillance, which was continuing, can continue. And most important is, enough stress is not being given all over to genome sequencing, which I believe, again, is quite important. Having said all that, my feeling, again, that we are not out of the woods. Some engineering measures have to be given a due importance in relation to better ventilation, better filtration. I think it was Peter Hurst in earlier meets who mentioned about it. I'd like to catch up with those developments, and maybe that may have to be promoted. And the last bullet point I would say, which Iman has also mentioned, let us remain prepared for this and for any other.
I am really sorry to hear there's another surge picking up in India. The previous one was really very awful, and gosh, please all look after yourselves and practice relevant precautions. Thank you. I said, Magan, I just want to check to see, I know you say your internet's not working. Let's just see what happens.
Okay, hello.
Hello.
Can I try to put the video on? Can you hear me?
Yes, personally,
Hello?
I can. I'll tell you if I can't. Yeah.
Yeah, okay. I've moved to another place. It seems I'm now in my bedroom. It seems it's better here.
Oh, very good.
The network is better, yeah.
You're still in Gaborone, in Botswana?
Yes, yeah. In Gaborone, testing is not ongoing anymore. People just get tested if they are feeling sick. So the numbers are quite low. I think the numbers that have just been reported are about 3,000 infections and about 300 deaths. But I think this is only for those who were sick, because if in traveling, if you have received your first booster, you don't get a PCR test, you just travel across borders. So not many cases are being reported. Then I'm not so sure about long COVID, because remember I contracted COVID, and I suspect I have some of those long COVID symptoms, because once in a while I run short of breath and I cough at times here and there. It has been about more than 3 months, so this should have stopped. So my doctor suspects those are symptoms of long COVID. So I'm hoping I'll have full recovery because I hate especially shortness of breath, because I'm a person who likes exercising, so it's very difficult, though I'm trying. And we haven't had so many cases at work. People are still masking, but nothing happens if you don't mask. So it's a matter of choice. So if you go outside, most people are wearing their masks, but some are not. So the mandates are not like as stringent as they were before the few cases. So you can decide even to travel without a mask, you won't be fined now. Even if you meet police officers, they won't even ask you.
Right.
So it's a bit relaxed. So, and we are now in winter, so we are a bit scared that maybe we will have a surge. I don't know. I'm just praying that we won't have, say, a surge, and I won't contract COVID again for a second time. Yeah.
Thank you very much indeed. It's just lovely to see you. And it's lovely that you choose to check in with us. We hope that you can continue to be with us. And all I would say personally is I know you like exercising, but don't push yourself. If your body is saying it doesn't want to, don't push it beyond what is comfortable. I'm sure there are others who will advise you here. Perhaps they will give different advice. Let's see whether Jo Nichols wants to give her internet a try. I appreciate that you may not want to. So if nothing happens in response to this invitation, I'll move on. Jo. Okay. Jo did say that it wasn't really working very well. Autumn Lerner from the Pandemic Action Network.
Yeah, hi everyone. Thank you, David, for continuing to convene this group. It is so valuable. Glad you're feeling better.
Yes.
You know, we are currently doing the hopscotch from political moment to political moment. From G20 meetings to the G7 Leader Summit is at the end of the month, and we're also looking forward to the UN General Assembly in September. All of that being said, I think the issue of fatigue and complacency that so many of you have raised with regard to publics or in the clinical space is really true at the political level. We're very concerned that pandemics continue to be relegated to health issues and kind of the issues of health ministers, while we really know that they are cross-cutting issues. And so we're really looking at how we can elevate the narrative in terms of addressing the COVID crisis, and pandemic preparedness is really an issue that cuts across from a security perspective, from an economic perspective, from a social perspective, also health, but all of these things are integrated. But right now, our focus is continuing to make sure that ending the COVID crisis and ensuring we're better prepared next time continues to be on the agenda for these key political moments. So that's what's top of mind. Over. Oh, you're on mute, David.
Sometimes I become a bit dyslexic. I mean, I can't move my mouse around right, but that wasn't a COVID effect. That was me just being incompetent. Sorry for that. Autumn, you know, I don't know what keeps you going, but please share some of that amazing energy with the rest of us, because, you know, you really are trying to keep the issue on the agenda. And it has to be on the agenda given the magnitude of the economic and societal consequences. But for all sorts of understandable reasons, political leaders like to kind of turn their back on it and say, it's done, it's over, but let's get on. And so thank you. Here's another one who keeps going in the most wonderful and extraordinary way, Gregory Harold, who's just at the center of the communications team at WHO, and is the main support actually to those of us who are working as special envoys for the WHO on COVID. Gregory, your thought.
David, thank you very, very much, and a real pleasure to join this group. Thank you. It's the first time I've been here, and fascinating listening to everything. And I know that as in all other domains of the COVID response, the world and we are suffering from communications fatigue, or maybe better than even calling it a fatigue, it's calling, we are dependent many times, if we want to get messages out, on having receptive outlets in the media. And there's no appetite these days for anything special on COVID. I think just because the tack that we take is something which is nothing new for editors, and also there is a great deal of COVID fatigue, as we've talked about. So if we want to talk about the need for social distancing, the need for wearing masks, the need for not being in too crowded places, the need for more testing or to continue testing and surveillance, I think these are messages which we trumpet every week, for example, in our press briefings, and every week our specialists on the social media chats that we have. So it's at least twice a week that these come out. And they don't make a difference. I think, as everyone else has said on this call, the wave is moving against us. So we would have to do something different. And the question is, for me at least, if we do this something different, is it something that we would want to use almost like scare tactics with? And this is a big question which would have to be debated, because what I've been hearing on this call is that if I've heard correctly, with Omicron, for example, there's a greater chance of long COVID. Studies are starting to come out like that. And long COVID is devastating in so many ways. And yet people really don't know or have an appreciation of how debilitating long COVID can be. And perhaps it's time that we start moving to emphasize that. But it's a track that one would have to go down with a lot of thought, I think, beforehand, because it is something which is negative.
Yeah.
And that is something to really bear in mind. So again, the fact that Omicron B4 and B5 seem to be causing a lot more cases. At the same time, David, you mentioned when you opened the talk that you believe that it's moving to the upper respiratory tract, not so much in the lungs.
Yeah.
So because of that, all of a sudden people are going to think, well, so what? We get something in the upper respiratory tract, it's not going to be dangerous. So again, disregard. Anyway, those are my thoughts. We're not going to solve anything here, but thank you very much for all the excellent discussion.
Yeah, and it's so important that we are not scared of debating and discussing these issues. They are so important. If we close each other down, that doesn't work. And Gregory, what you and others are doing, and particularly maintaining the dialogue, is just so valuable. Can I just say one thing? You said that you feel that perhaps the WHO work is not having much impact. I would like to say to you that I think WHO's work is having an enormous impact. Just imagine what it would be like if there wasn't the regular work being done by Tedros, being done by your team, the work that you do with influencers and so on. It could be a lot worse. And some folk have said that they believe that over time, the positive views of the World Health Organization have actually increased, particularly in the last few months. So we don't have the counterfactual. It's one of the problems with doing the kind of work we all do. We can't test to see what life would be like if we weren't here and if we weren't doing it. It's the same with all systems work. You don't necessarily have that nice feeling of success. And let's kind of go to John Atkinson.
Can I add one thing first, David?
Yes,
Sorry,
of course.
Just to say that I think you're very right in what you say, or how you caveated what I said, because I think what I was saying is that what's happened is we have quite much less uptake with the media at the moment. But I do think that, as you quite rightly say, with influencers, with public health officials, with professionals, so to speak, there is still a lot which WHO is doing, continues to do, and hopefully we're taken quite seriously. And I do think that we're being almost, if you like, vindicated at the end of the day. There was a lot of negativity, I suppose, early on, and there will always be people who peddle misinformation.
Yeah.
But on the whole, I think, yeah, thank you very much. I'll leave it there.
But just to say, super important what you're saying. Sometimes people ask me, what is WHO? I say it's really the network of public health actors. People like Frank, who's still with us, and others are prepared to network into WHO processes and see themselves as really part of that global system. They identify with it, they respect each other, they share, and they mostly trust each other an awful lot. For me, that's been so important. Let's go to John Atkinson, please.
Thanks, David. I'm going to start from something Frank said about relying on public behaviour, and remind you how many times you probably need little reminding that you said people are the solution. We said at the start, the more we can get more people doing more of the right things more of the time, the better position we're in. So, what does it take to do that? What makes that happen? Well, there's a very clear leadership space in this. That's first about identity. Who is the we who are doing things together? Who do we care for? When we say solidarity, who are we including? Seen comments in the chat from my country about how we seem to be alienating people, and this sense of look after our own only acts against. So there's an act about identity, about making sure that people sense a larger we that we belong to. There's something about relationships. Who do we connect to? Who do we trust? Who do we pass our intelligence with? Who do we pay attention to? Who do we follow? Who are the influencers? Is it national, global press? Is it someone on TikTok? Who are we connected to in that way? Mm-hmm. And then it's something about information. And this goes to, I think, some of the conversation that's been going on in the chat, really, which is how do we make accessible, visible, transparent, trusted information so that people can make informed appreciations of the risk that they face, whether that's about vaccines, whether that's about infection, whether that's about long COVID, whatever it is. But if leaders focus on those things, shaping identity, strengthening relationships, and sharing trusted, good, high quality information, then that's what allows, that's what sort of ferments, if you like, this sense of collective action in a direction that's more helpful. So that's really what I've been thinking about listening to the conversation today.
And were you saying ferments, F-E-R-M-E-N-T-S?
I might have been. I'm not sure if it was the right.
That ferments it. But no, I think it's a beautiful concept because that leads to a lot of bubbling and energy. But Frank is saying foment. Yeah. So Frank, you're here. So, can you turn on your video and just give us your last thoughts as you're leaving? We love hearing you. We love it when you come.
No, this is a fascinating conversation. I'm very grateful to everybody, and one of the things I was just thinking about, and it's John triggered the thought really about, trust, and we don't trust politicians very much, certainly in the UK at the moment. Journalists, get a bit of trust, but not very much. Lawyers, very little. But people still do trust, doctors and WHO, and I think. That the pandemic has actually strengthened the trust in local directors of public health, I'm thinking, and local public health leaders, and they do separate that from the kind of political voices. So I think we need to build on that, David, and use those voices and that credibility that we've collectively built during the pandemic in our responses, and use that on all the other issues, the climate change, the food insecurity, the conflict issues that you've talked about before. Yeah. So that would be my final thought really for today.
So to Frank Atherton, CMO Wales, to all of you who've joined, don't want to mention you all by name, but everybody here is a leader in their own space. Everybody here inspires others. Everybody here inspires this community, and everybody here, I believe, values this community. Otherwise, why would you come back for an hour every 2 weeks. It's so wonderful that you're here. Mahika Acharya is very much looking after us. And Mahika, I'd like you to just say a word or two about the next session, but also how people can stay in touch with each other. Mahika,
yeah, sure. Thank you so much,
now.
everyone, for attending. Thank you to our regulars. Thank you to those who've joined for the first time. And I hope that we'll have WHO as well for the next sessions. Thank you to those who shared and for everyone for listening and for making the time. Our next meeting is on 1st July. So please feel free to invite anyone. You know, it's an open meeting. And to end, I also just wanted to stress what David and John and Annie had mentioned about solidarity and how communities like this one really provide the support and information and kindness, I think, as well to us as individuals, which we can then take to our communities and our spheres of influence. So thank you all very much and see you all at the next meeting.
Thank you.
Bye-bye. Thank you.